At the outset, let me thank the INSL for giving me this opportunity of discussing genetic risk of alcohol use disorder and ALD and MASL, similarities and differences. At the outset, my disclaimer that I am not somebody who is an expert in genetics, but trying to understand how this entire data on GWAS and whole exome sequencing is going to affect us taking decisions in day-to-day practice. So this talk is sort of geared around more on how to implement rather than sort of give the details of genetics. So greetings from the liver unit at Gleneagles Hospital in Mumbai, where I am. All of us would know and understand that not all patients who consume alcohol get alcoholic liver disease. Similarly, patients who have got steatotic liver disease, not all progress to steatohepatitis, cirrhosis and hepatocellular carcinoma. So there are genes involved at every step, whether the person who is consuming alcohol gets alcohol use disorder, or whether a person who has got steatotic liver will progress. Now there have been very elegant studies done on twins which tell us that monozygotic twins have a larger problem than dizygotic twins, who have a larger problem than siblings and the spouses. So it's very clear that genes do play a role in all this. And let us see what are the similarities and differences. So you will realize that between alcohol and eating disorder, there are a lot of similarities. As we go along, we will know. Let us start with alcohol. So we all know that alcohol is metabolized by alcohol dehydrogenase to acetaldehyde, and acetaldehyde is then further metabolized to acetate by aldehyde dehydrogenase. So genes which regulate this will definitely have implications on the metabolism and the patient having alcohol related liver injury related to the metabolism. Not only that, there are genes which affect the beta oxidation and reactive oxygen species production, also genes which affect the inflammation. So not only the alcohol metabolism, but alcohol causing liver injury is mediated by genes. Now alcohol causing steatotic liver disease, lipogenesis and progression related to that, these genes are common to steatotic liver disease of the metabolic variety. So there is some common genetic factors which involve alcoholic steatotic liver disease and metabolism associated liver disease. So we have realized that in the metabolism of alcohol, if there is aldehyde dehydrogenase, which there is a genetic mutation and variation, then these patients cannot tolerate alcohol because the flushing which they get is overpowering and actually they stop drinking alcohol. So this is a protective mechanism which comes up because of their genetic variation. So that is important. On the other hand, there are genes which metabolize the alcohol and make the patient susceptible by increasing the liver injury, or more interestingly, there are genes in the KRAS and the dopamine receptors which actually cause in the brain a reward mechanism and make the patient an addict. So alcohol can be having a different response in different individuals depending on the genetic variations as far as either protection or susceptibility, and susceptibility in the form of either liver injury or in the form of alcohol use disorder by making the patient addict. These are obviously different than the steatotic liver disease, because such sort of metabolic issues don't come up with steatotic liver disease. Let's switch on to obesity. As far as obesity is concerned, it is very clear cut that there are two types of disorders. Again, this is different from the alcohol. In alcohol, you do not have a monogenic type of disorder where you have a single mutation in one gene causing high penetration where there is no environmental influence. So, this is the pure monogenic obesity where you have very early onset and severe obesity. Compare that to the common garden variety obesity which we see in day-to-day practice, that is polygenic, compared to the monogenic ones where there is syndromic obesity. So, here on the right hand side you see polygenic, the common variety of obesity, where there are hundreds of variants which are identified. So, there is no single gene mutation, there is low penetration of this genetic variation, and environment plays a key factor unlike the monogenic variety. So, in obesity there are two distinct type of genetic penetrance. Now, this leptin melanocortin pathway in the brain plays a very crucial role in the feeding and these satiety regulation in the brain. So, leptin as a hormone, we know that when the patient is well fed, the leptin levels are high, it suppresses the causes satiety and suppresses hunger. If the levels are low, then there is increased appetite. So, there are genes which are in the arcuate nucleus and the paraventricular nucleus in the brain which are responsible for this satiety and hunger sort of cycle. So, leptin receptor, the pro-opiomelanocortin pathway, the PCSK1 and the melanocortin 4 receptors. These are important as far as the hunger is concerned and the satiety is concerned. There are genetic mutations noted in these 4 genes: leptin receptor, POMC, PCSK1 and MC4R, which cause the syndromic type of obesity. Now, the important thing is that this gives us an option in trying to treat it. So, in all this there are 2 steps which are known. If there is a leptin deficiency, then you can give leptin and actually reduce the obesity. So, these patients who have this monogenic form of obesity are given leptin if they have a leptin receptor problem. The other, there is a drug which is given for leptin receptor genetic mutations. So, this gives us an opportunity to treat these patients. Such things are not available in alcoholic liver disease. For the common garden variety of obesity, there is a FTO gene which is noted across all GWAS studies. In experimental animals, also in mice, if you have leptin, if you have the FTO gene deficient, then the mice are lean. If there is an overexpression of the FTO gene, then the mice are obese. Same thing is known with the BMI in humans. So, studies are correlating. However, if you see on the bottom, the meta-analysis had taken up 45 studies with 2,40,000 subjects. Yes, surely enough, if the FTO gene was present, there was a 23% higher risk. However, a person with FTO gene, if that person is physically active, there is a 30% lower risk. So, you can actually modify your genetic deficit by good environmental control. I think this is something to remember. as far as steatotic liver disease are concerned, the progress from a healthy liver to steatosis to state of hepatitis to cirrhosis and hepatocellular carcinoma, there have been 4 genes noted: PNPLA3, TM6, SF2, MBOT7, GCKR. These all affect the metabolism of fat in the liver and cause fatty liver. There are 2 genes at the bottom which are supposedly having a protective effect. So even if you have PNPLA3 positive, if you have HSD gene, then you are protected from the PNPLA3's variant. So these are some of the genes which are commonly noted in the large studies which have been done on steatotic liver disease. So when you have so many genes, how do you then try to find out whether in your patient, is the patient likely to have a problem? So that's why a polygenic risk score has been derived both for alcoholic liver disease and for metabolism associated liver disease. Interestingly, the same genes are in both alcohol and MASLD. So if you see the genes which have been looked at in the alcoholic liver disease, it is PNPLA3, HSDs, TM6, these are the same ones which are in the lower thing, in the metabolism associated. Because as we said, once there is steatosis, the further progression is governed by the same genes, whether the patient has got alcoholic liver disease or whether the patient has got metabolism associated steatotic liver disease. So this is how you make a polygenic risk score, by utilizing the genes and giving them appropriate sort of scoring. In the alcoholic liver disease, it was noted that if you added diabetes, so one of the metabolic factors, then you had a 10 times more risk of alcoholic liver disease with the presence of these genes. Similarly, people have tried to use clinical data of age, diabetes, dyslipidemia and liver function test and come up with a clinical score and add to the polygenic risk score and come up with a score of how the patient can be affected. All these are good as far as scores are concerned, but doesn't really help. Suppose you have a person with a high score, how can you interpret that in real life? So this is predicting obesity. If you have, so this is the topmost line is the highest percentile. So if you have a score in the highest percentile, you would expect that everybody should be obese if you have that gene. But no, only 4 out of 10 become obese. So that it doesn't help you in real life. On the contrary, if you have a low risk, if you are on the lower genetic risk, then you should not have obesity, but still you find a lot of individuals on the extreme right being obese. So both the positive and the negative predictive value is not good as far as these scores are concerned. So how does it leave us? To summarize, alcohol use disorders and alcoholic liver disease and metabolism associated liver disease share many similarities on genetic predisposition. They lead only a fraction to progressive disease. Despite identification of a large number of genes on Jiva's causality and pathogenic mechanisms, so the causality and pathogenic mechanisms still need to be elucidated for most of these variants. The pursuit is for translation of the discovery of the gene to, number 1, predicting the at-risk individuals, number 2, identify those who are at a risk of progression, and number 3, identify therapeutic targets. As I said, only 2 have been so far, that also in the syndromic type of obesity. So I will leave you behind with this sort of thought that heredity is not destiny. Just because you have a gene, it doesn't mean that you cannot counteract it. Genes determine who is affected. Environment determines how many are affected. So by changing the environment, you may be able to take care of at least some of the patients who have a bad gene. Thank you.